Good morning or afternoon, depending on where you're joining us. It is my pleasure to welcome you to the practice-focused webinar entitled Real-World Experiences Using Ultrafiltration in the Management of Heart Failure Patients. CHF Solutions is honored to host this educational webinar to provide valuable, provocative, real-world insights on treating fluid overload in heart failure patients. All participants will be in listen-only mode. After the presentation, there will be an opportunity to ask questions by submitting them through the Q&A panel located at the bottom of your screen. Participants of this call are advised that the content of this presentation is being recorded for playback purposes. A replay of the presentation will be available on the CHF Solutions YouTube channel in 24 hours. And on the website at www.chf-solutions.com, located under the Investors tab, then Events and Presentations. Today's webinar will be moderated by Dr. John Jeffries. Dr. Jeffries is the J. Michael Sullivan Distinguished Chair in Cardiology and the Director of the Cardiovascular Institute at Methodist, the University of Tennessee. He is a professor and chief for the of Adult Cardiovascular Diseases, Professor of Preventive Medicine and Pediatric Cardiology at the Le Children's Hospital, and a research member at the St. Jude's Research Hospital. Dr. Jeffries is joined today by an esteemed panel of researchers, and practitioners from the Abington Jefferson Hospital System in Philadelphia. Dr. Robert Watson is an interventional cardiologist. He is the Chief of Cardiology Division and the co-director of the Comprehensive Heart Failure Program. Dr. Donald Haas is a heart failure cardiologist and medical director for the Mechanical Circulatory Support Program. He also is the co-director for the Comprehensive Heart Failure Program. Maureen Hummel is a nurse practitioner and the clinical director for the Comprehensive Heart Failure Program. And Patty Barella is the clinical specialist and the heart failure coordinator. Thank you all for sharing with us this important research with the audience. All of today's panelists have been involved in treating heart failure patients for many decades. Here are our forward-looking statements and indications for the Aquadex SmartFlow system. Here are the speaker's disclosures. And now it's my pleasure to turn the program over to Dr. Jeffries. Thank you, Dr. Jeffries.
Thank you, Linda, and thank you to everyone for attending today. I hope this is helpful and maybe provides some insights. And I'm sure everyone is familiar with ultrafiltration. It's been a long-standing technology. I think what we want to do is bring you a contemporary view of aquapheresis in 2021 about, how do we really interpret existing data and what are some real world experiences, which we'll be fortunate to hear about on the latter part of the talk. Next slide. Heart failure continues to be a major problem in the United States and accounts for a lot of hospitalizations, leading hospitalizations for adults over the age of 65 in the US. And there are well over 1 million heart failure hospitalizations in the US alone. And hypervolemia is the predominant cause. And I think that's an important caveat for us to think about right now, is that hypervolemia really is the driver of, and this volume overload is really the problem that we're dealing with. And that's going to be important when we talk about things like existing trials such as CARESS-HF. The average length of stay currently in the United States is about 5 days. And we all know that heart failure hospitalizations are a strong predictor of mortality. And actually with each successive admission, you have a stepwise increase in your mortality. So that's something that we need to try and avoid. And unfortunately, up to a quarter of patients will be readmitted within 30 days, and up to 50% of heart failure patients will be readmitted within 6 months. And as I just said, we are hastening their mortality. So anything that we can do to get them out of the hospital and keep them out of the hospital is paramount. So we know since 2012 that Medicare has been levying penalties for those 30-day readmissions if the rate is above that of as expected. And you can find those out for your local areas, and they can be quite costly to hospital systems. And we know that you can lose up to 3% of Medicare reimbursement for all admissions because of violation of these penalties. Next. So currently, most places, I think, across the globe, the ongoing strategy, which hasn't changed since I was a medical student, is to give diuretics. And we all know that they can be somewhat effective, and you can give them, and it's relatively cheap, relatively easy. And sometimes you get a reasonable response. But we all know that unfortunately there's a bit of a mixed bag when we talk about using diuretics. So we know that the longer a patient is on diuretics, the less effective they become. So this idea of resistance or tachyphylaxis, high incidence of poor diuretic response. So we know maybe 40% or so show poor diuretic response, and we know many patients will show a suboptimal response. And then we know the use of diuretics oftentimes results in a rehospitalization. And all of these things, as you can appreciate, portend a significant adverse clinical event, such as the idea of worsening renal function or change in decline in GFR. We know, there can be disturbances in electrolytes and ultimate hypotension. And remember that, chronic use of these diuretics as well causes problems. They actually can cause negative impacts on kidney function over time. So a thoughtful use of diuretics has to be employed. And I think we all believe that there is an appropriate place to use diuretics. But they shouldn't be the only option considered when someone presents with an acute decompensation. Next. The ADHERE registry, unfortunately, which isn't funded anymore, but we were a part of for a long time, was an outstanding resource that gave us a lot of ideas about heart failure in general. There were over 50,000 patients that were enrolled and followed longitudinally. And you can see that many patients are discharged with a weight loss of less than 5 pounds. And actually some are discharged with weight gain. And I think this is the concept that I hope everyone takes away, is the idea of volume overload is critical. And I feel confident in saying that most people are discharged from emergency rooms or hospitals in the United States, and they are not adequately compensated, period. They still have excess fluid. And remember, what you're doing with something like a diuretic is great, but you're only mobilizing intravascular volume. So it doesn't mean they're still not volume overloaded, even though the creatinine may jump a little bit. So these are important concepts when we talk about this, and we know if they're not adequately decongested, they will come back. So this is an important component to heart failure management that I don't think we pay a lot of attention to, because as practitioners, we're all under the gun to get patients out of the emergency room or out of the hospital. And if there's a way that we could do that more effectively and maybe less than that 5-day typical hospital stay, I think that would be an effective opportunity that would probably make everyone happy. Next. So obviously we're talking a bit about ultrafiltration, and I've used this technology for over a decade. We've used it in HFrEF, we've used it in HFpEF, I've used it in pediatrics, I've used it in neonates, and it's very effective, and the safety profile from my perspective has been outstanding. And I think a few important points that you want to take away is that, one, we know that we're not going to have major perturbations in electrolyte levels, which is key, right? You have a cardiac patient, ideas of hypokalemia, hypomagnesemia are not favorable. We know that diuretics actually upstimulate things like the RAS system, and this actually has a favorable impact. It stabilizes or improves hemodynamics because it's a continuous unloading. You're not seeing these drastic shifts when someone may drop 2 liters with a dose of 100 milligrams of Lasix. We know that you can restore some of the efficacy of diuretics secondary to the use of ultrafiltration. And these are some published data that about a 50% reduction in the risk of rehospitalization for heart failure compared to diuretics. And that's a big deal because that means many hospital systems may get under that penalty level. And then we know that early initiation in acute decompensation appears to at least to reestablish euvolemia pretty well. And we do think it may decrease hospital length of stay. Next. So this is a whirlwind of some of the existing data, and this is not all encompassing as you might guess, but you can appreciate research in this area has been going on for some time. Nearly 2 decades ago, the SAFE study was published, and you can appreciate that safety was there and efficacy you can see in Euphoria. And there are some trials that led up to, sort of a critical turning point in the use of this technology in cardiology. We had rapid HF and unload, both of which were viewed to be positive. But then we came to Caress, and this was sort of a pivotal trial published in New England Journal. And the concern was that it wasn't a positive study. And I'll tell you just from our view that actually, if you revisit how Caress was done, it actually was a relatively poorly designed study. And you'll hear more about how this technology is used, but you have to remember that you can modulate how much fluid you can take off on an hourly basis. And in Caress, you were predefined to take off exactly 200 cc's per hour. Well, you can imagine some people may need more in an hour, some people may need less. So there are inherent problems with this trial, and it was thought that it was ineffective because the weight loss was similar between the two groups, and that maybe ultrafiltration had a mild increase in creatinine as compared to diuretics. However, if you go back and reanalyze the data, and I'm happy to supply these papers to you, it actually, if you look at it, it was very similar across these changes in creatinine. And actually, the folks that were properly enrolled actually had a higher amount of fluid, so they had a higher net weight loss than those on diuretics. So everyone refers to this trial, but I would encourage you to read it and see what you think, but recognize there were inherent limitations that sort of, I think, negatively impacted the opportunity of aquapheresis to actually show what it can do. And then Avoid HF was a study that was in JACC heart failure. The study was stopped early, but at least in the data that were accrued, these were all positive findings. Next. So I'll turn it over to the team to talk more about the real world experience. And I'll just throw in our own little caveat is that we've had similar experiences to what you will hear about. And we've actually reduced our 30 and 60-day readmissions by nearly 60%. So we do believe that in the right hands, this technology can be essentially a game changer for how you manage inpatient heart failure. Thank you.
Thank you. So we created a comprehensive heart failure team to which 3 out of the 4 people that are listed on this paper have been together since the beginning of this program. That's Maureen Hummel and Patty Barella. 2012, Dr. Haas was hired to be our advanced heart failure physician to advance our mechanical circulatory support as well as our heart failure team. But in saying that, we've been learning for the last 13 years how to best utilize aquapheresis in our patient population. And so that when we'll talk about the randomized trial data here in a second, you have to realize this only encompasses about 3 to 4% of the patient population that we treat on a routine basis. But in saying that, it has been able to demonstrate that 3 to 4% of the population have improved their readmission rate and their survival rate significantly with the utilization of this technology. So I think that if we could go to the next slide, that would be great. So we performed a retrospective single center analysis of 335 patients between July 2009 and June of 2019. We utilized CHF Solutions Aquadex Flex Flow system throughout that time, despite the variations in ownership of that technology. And as Dr. Jeffries alluded to, we performed adjustable rates based upon clinical monitoring parameters. And we ran the ultrafiltration through our advanced heart failure center. So it wasn't a bunch of hospitalists or cardiologists or nephrologists or whoever wanted to run this study. Next slide. The results were pretty staggering. We looked at them. Our mean age, we're one of the oldest regions in the country. Our mean age was 73. As you can see, 57% of the gender were male. It was almost 50-50 between heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Mean systemic blood pressure was stable, and our creatinine was a little bit higher than some of the previous studies, but still at about a stage 2 to stage 3. The number of hospitalizations that this patient population had prior to the initiation of aquapheresis was similar to this same population of 2.14 per year. Next slide. So when we started ultrafiltration, this was all part of kind of bringing this in and showing this new technology to the referring physicians. It took a while because diuretics are still the mainstay of therapy for decongestion of the heart failure population. So after the heart failure population, which we were consulted on, initiated ultrafiltration, it was later in their hospitalization. And a lot of this had to do with refractory edema as well as progressive cardiorenal syndrome. We would start at about 150 cc's an hour compared to the CREST trial, which started at 200 an hour and kept it that way. And we adjusted the rates based upon hemodynamics, urine output, routine laboratory data. We halfway through this trial, we started doing diagnostic right heart catheterization to define their central congestion and their cardiac indices prior to initiation. And that's where the 27% of patients, or a significant number of them, started having inotropic therapy added to their regimen. Despite this sick population, we had a major bleed rate of only about 3.6, since anticoagulation is required to reduce the risk of complications, mainly of clogging the filter, which is not a cheap process. And as you can see, out of the 335, 215 had undergone right heart catheterization. Next slide, please. When we looked at the renal function changes, the mean serum creatinine immediately post-ultrafiltration went up 0.11. As the previous clinical trials of Maureen Hummel will get into, as well as Dr. Jeffries explained, 0.3 was kind of a cutoff in some of these trials. Even prior to discharge, the serum creatinine had come down, and then it maintained at a lower level even 30 days out. And we did decongest these patients. The mean fluid volume removal was almost 15 liters, and the weight loss was close to 16 pounds. And yes, we did have some people that had significant weight reduction during their procedures. Next slide. The outcomes compared to 30-day rehospitalization, which for the normal heart failure patient was 25%. This population, which we felt was even sicker than the normal, had a rehospitalization of 12.4%. 90-day hospitalizations to 60-day was 14.83. So it's pretty significant reduction compared to 50% at 6 months and 1 year being 27%. And as you can see, the reduction in rehospitalization was significant in this patient population. Next slide. So at this, what I would like to do is turn it over to Maureen Hummel, who her and Patty crunched a lot of this data and put it together and really looked at the comparison of these trials. So Maureen.
So welcome everybody. Thank you for attending today. But what we've tried to do was compare our experience in a real world format to what had been shown in previous trials, all of which were reporting things a little bit differently. And so I'll try to explain those differences as I go here. But as Dr. Watson was alluding to, we were certainly an older cohort than those in the unlow CREST dose, which of course is just a diuretic trial, not a UF trial, but then also a void. And when we look at the mean creatinine at baseline for our population, it was pretty much on par with the CARES trial, which was a little bit worse in terms of renal function as well, although they reported their creatinine in terms of a median number, not a mean. So perhaps it was actually a little bit better than ours. In terms of the blood pressures, systolic blood pressure at baseline, we were very similar across all of the trials. And then again, when we look at the mean number of hospitalizations in the prior year, our patients, we could say had a correlation of a sicker profile in the sense that they had more hospitalizations at 2.1. Again, there's some differences in the reporting in that in CARES and DOSE, they reported the previous year's hospitalizations in terms of a percentage as opposed to an actual number. And then some other differences in terms of our cohort was that we had a higher percentage of HFpEF versus HFrEF in terms of our population. Next slide. And then again, looking at the creatinine change comparatively to other trials, we were actually a little bit better in terms of our outcomes than CARES. And as Dr. Jeffries had previously alluded to, CARES had some faulty design issues in terms of allocating what we would call, in our experience, a pretty high UF rate that was an arbitrary number, designed into the trial. And we adjust our rates quite a bit, which was not the case in CARES. So that perhaps was really something that was factorial there. And then in terms of, longer term follow-up with our renal function, again, and even comparing to AVOID, perhaps it was a little bit better in our cohort. The other thing that in terms of difference in reporting, looking at that signal, at least by virtue of the literature, and albeit this is changing to be a little bit more less conservative, that an increase in serum creatinine of greater than 0.3 milligrams per deciliter is thought to be a signal for worsening renal function. And we looked at our cohort, and 25.45% of those patients during the course of therapy had that type of an increase that tended to improve a bit afterward. But nonetheless, the only other trial that had that reported out was the DOSE trial. Again, looking not at UF, but diuretics. And, our experience was a little bit better in that regard as well. Next slide. And then looking at, signals for decongestion or parameters of decongestion. And when we compare ourselves with the other trials in terms of UF, again, some differences in terms of the length of the therapy. Unload was a 48-hour process, CARES a bit longer or shorter, depending on the individual patient. And AVOID, AVOID really was the stellar outcome at 23 liters, but nonetheless, we bested the others with almost 16 liters. 16 pounds of weight loss. Again, in terms of, removal in terms of fluid in liters, again, a similar experience in relation to the other trials. Next slide. And then lastly, in terms of readmission, and again, differences in terms of how this was reported out. Not everybody reported out 30 days or 90 days. The only report out in terms of CARES was 60-day readmission, hospitalization for heart failure. And when we compare our experience, the experience at Abington really was on par at 1 year with what CARES was at 60 days in terms of readmission for heart failure. And with that, I will hand back to Dr. Watson.
One point of reference is that the rehospitalizations for our trial were all rehospitalizations for patients who received therapy with aquapheresis. And the other trials were a comparison of aquapheresis with loop diuretics. So, but in stating that, I think that the fact that we felt that this was a sicker population, the troubled patients, as a lot of institutions will discuss and talk about in their normal rounds, we felt very fortunate with regard to this data. And speaking of that, I think that I'd like to ask Patty Barella, since she's my nurse specialist who has to deal with the actual patient care 24/7 of the people getting care on our heart failure floor to discuss some of the pearls that she has taught other nursing staff and other physicians over the last decade on how to treat this patient population. And then finally, we'll come back to Dr. Haas, and hopefully Dr. Haas can talk about patient selections in his mind who have done best with this therapy versus not. So Patty?
Yeah, thank you, Dr. Watson. So I think what's important to making a program successful is the education that your nurses that are going to be with these people 24 hours a day are getting, that they recognize plasma refill, they recognize how important it is to, we hold the therapy, we have standing orders to hold the therapy for that and things like that. And as I said, having a heart failure nurse team and our heart failure specialty inpatient program managing this, make this very successful. We do a lot of education with the nurses, and we also do a competency with them every year. And we do a competency with them every year as well. Can you hear me now? Yes. We do a competency with them every year as well. So I think that getting the team on board, the education, helping people to really understand how this is working is the key to the success, one of the keys to the successes that we've had here.
So yeah, I think the most important thing is the right heart catheterization. The hemodynamic profile of these patients going in is critical to avoid the complications, principally progression of renal failure on, onward towards dialysis. One of the things that is typically these patients who are being referred for ultrafiltration, it's obvious that they're volume overloaded. What you really need to know is their cardiac output. And that's where the utility of the right heart catheterization comes in. In addition to confirming what you think their intravascular volume status may be, and of course, sometimes you could be surprised by that, you learn what the cardiac index is. And even if their index is down, it doesn't mean that you can't do ultrafiltration. But it often means, in our experience, definitely need to have some kind of support, either with milrinone or dobutamine, in order to get them through the ultrafiltration session. Another thing that often comes out of a right heart catheterization is that you find that there could be a predominant picture hemodynamic profile of right ventricular failure. And that's typically characterized by a very high CVP and a proportionally low pulmonary artery systolic pressure. And so there again, giving inotropic support to the right ventricle is very effective at getting you through ultrafiltration. The one particular hemodynamic variable that I think you have to have a lot of healthy respect for is the blood pressure. Clearly, the mean arterial pressure is a potent predictor of folks who are not going to tolerate ultrafiltration well. Generally, you like to see them at least over 115 if you can. I think if they're under 90, it's probably not safe to do. Now, whether or not you could transiently add in a vasoconstrictor to help get them through ultrafiltration, certainly it could be done. But clearly at that point, you're dealing with a patient population that is very much at high risk to have progression of worsening renal failure despite the ultrafiltration. And that's one of the discussions that you need to have with these patients. The value of a right heart catheterization with these folks is that you get that, so you will often come back and you will have a situation where you clearly document without any question that they are intravascularly volume overloaded. And on top of that, you've documented that their cardiac output is normal, right? So in that situation, volume has to come off, period. End of discussion. People can't walk around volume overloaded because not only are their legs congested, which everybody talks about their edema, but what matters a hell of a lot more is how congested their liver is and their kidneys are, et cetera. So when you see that volume overloaded state, you've got to intervene on that volume overloaded state. Now, if the cardiac output is normal, right, and presumably by the time you're getting them, they may have failed diuretics or something. The point is that if the renal function worsens despite volume removal, to me, as a heart failure doctor, I've learned all I need to hear because they're telling me that patient, the only way they're out of this mess is through dialysis. Now, talking about dialysis is obviously a very big step, and that's not an easy conversation that rolls off the tongue. And very often patients may get readmitted 2 or 3 times later before they actually agree to dialysis. But if they can't tolerate volume removal, especially after you've documented those high filling pressures with a normal cardiac output, then you've said all you need to say. Now, again, sometimes you can augment that with an inotrope. But again, I think it's one of the real values of that whole process is like, whoa, take a step back and think about what you're talking about here. You've got somebody who's floridly congested with a depressed cardiac index who needs an inotrope to get the volume off. That patient's prognosis is horrendous, okay? And these are the folks that you need to be having discussions about advanced heart failure therapies, whatever they may be.
And I think it's really, establishing the learning curve and developing a team approach to this with high expertise and treat. If you're going to decongest, heart failure patients, you really need to have a high level of expertise in treating heart failure patients in general.
And I think that's important. And we've developed this program over so many years. And I think that we've learned so much through that time. One of the beauties of sharing this was because our outcomes were good, which is one of the reasons that Maureen and I wanted to really look at our data. But I think that you have to have a respect for it. You have to be sure that the people that are involved with this understand all the things that Dr. Watson and Maureen and Dr. Haas have mentioned, and Dr. Jeffries about volume removal in heart failure patients, which is an art and a science. So I think that it's important as you put all this together that you remember that as well.
I think that the process overall, as I stated earlier, is utilized at a small percentage of the overall population. I do think that as Unload and some of those trials have looked at reduced length of stay is based on the fact that they were admitted right out of our heart failure center to the floor and started aquapheresis on day 1, not on day 5. And they had high filling pressures centrally with or without normal cardiac indices and parameters. I mean, I think that as Dr. Jeffries, and he'll comment in closing, what people are theorizing is that aquapheresis is removal of isotonic fluid, which actually reduces the counterintuitive processes of the organs and kind of messes with them a little bit to allow them to relax. The braking phenomena that we see with loop diuretics on renal function kind of actually improves when they get their diuretic holiday for whatever period of time it is while they're getting aquapheresis. And the majority of the time we will reinitiate loop diuretics at 50% or less of their pre-hospital rate with the similar response. So there's a lot of people doing some research on neurohormonal deactivation and various biomarkers that we watch routinely to determine appropriateness of therapy. And I do think that from a patient standpoint, when you're undergoing aquapheresis and you walk in, you see there's a machine next to you, and you look and there's a bag full of isotonic saline, it's a reminder to them that they might not want to drink and eat so much salt, in the near future as well. So it's a good visual for these patients, and it's amazing how better they feel when they've been sleeping in a chair for months. They can go home and sleep in their bed. So I think that those are some of the success stories. What we didn't demonstrate in our talk is the percentage of patients that went on to dialysis, which Dr. Haas alluded to. It was still a small percentage. We have an automatic consultation with nephrology that we get along very well with if their serum creatinine is greater than 2.75 to begin with, because this seems to be this break point with regard to whether they're going to get decongested without worsening their cardiorenal syndrome or not. So it does work hand in hand. And I think it's very important to control the process through a team approach, because we did make adjustments in their ultrafiltration rate, and that adjustment sometimes could be 2 o'clock in the morning when Maureen or Patty are called by the nurse on the floor saying, Mrs. Jones' urine output dropped and blood pressure is an issue, and should we have them, go to refill for a while, and should we reduce the rate? So that's the real world experience.
Our point too, though, is that you don't want to be changing too many variables while this is going on. So oftentimes as I'm sure was mentioned, you stop diuretics, you stop the loop diuretics. And often I will hold the ACE inhibitors or the ARBs or the ARNIs just because I don't want any other factors that are going to kind of cloud it. We'll let their blood pressure run as high as we can get it.
Right.
We drive it down. You not live with a blood pressure of 140, for example, under normal circumstances. But we'll allow them to run at like 140 systolic, throughout the session and not chase after that. Simply for that reason, because we want to keep their pressures up to allow them to run the full 3 days on the filter. The other thing that I would say is as far as finding the right patients for this, I think there is a role, and I don't really have a good way of predicting who it is, but there are people whose intravascular volumes are not that terribly elevated. And certainly, proportionally much less than the peripheral edema, often, oncotic edema that you'll see, maybe some from nephrotic syndrome or something like that. And, the post-op patients, surgical patients, when they've been in the unit for 3 weeks and they're swollen up. And if you run ultrafiltration at a low rate, you can sometimes get away with it. You have to be careful and you have to do it slowly. It may, 100 cc's an hour. But often that can be an effective way to draw some of that volume that otherwise might not be amenable.
And it really takes a close look at your patient, on an individual basis. Not only, I think, looking at EF is from the left ventricle standpoint is really not that much of a differential, but RV dysfunction is a big one, as Dr. Haas was just alluding to. But I think really, it always gets down to this in medicine, but really good history taking to really define for maybe the first time, what is the actual euvolemic weight of this patient. Historically, I think what happens between all medical providers is they look back at what was the weighted discharge of the previous hospitalization for heart failure when they were volume overloaded. And, as we all know, we don't do a great job of decongesting, so that weight at discharge is faulty to begin with. And so really dig down, drill down, discussion with that patient. What was their weight? Maybe it was 9 months ago, when they had no edema, when they weren't short of breath. And wow, it's not just a 15-pound weight gain, it's a 45-pound weight gain from the last time they could actually portray a euvolemic state.
Well, thanks, everyone. That was outstanding. And I would encourage everyone who's on this really to pay close attention to what the team has accomplished. It really is about being thoughtful. And I do want everyone, and Dr. Watson alluded to this, and I think he's absolutely on target, is this idea of breaking a cycle, essentially. So you have diuretics on board and you're either chronically exposed and then you're going to increase those doses in acute decompensations. You are becoming more and more resistant to those diuretics over time. And by definition, they are augmenting your RAS pathway. And remember, heart failure is a systemic syndrome, right? And it's an inflammatory syndrome. So all these things have to be mitigated. And by pushing diuretics and just changing doses, you're really not breaking that cycle. Ultrafiltration, in my mind, in some ways is not dissimilar to VADS, and where I'm resting the LV, for example. I'm giving some opportunity for the kidney to reset itself, as Dr. Watson said. And that's hugely important for these patients, because otherwise you're just in the same spiral, and that spiral is going to go down eventually. So
and to that point, I think, and a lot of the complications stemming from diuretic therapy, with the electrolyte disturbances and the arrhythmias that we see, it is distinctly unusual in my experience. I've seen hyponatremia. I haven't seen a lot of hypokalemia or hypomagnesemia because it's isotonic. And so another group of patients that I think are useful to keep in mind for ultrafiltration are the ones where, okay, maybe they did respond to the diuretics. Maybe, you got off the 2.5 pounds, but, oh my gosh, the potassium's 2.9 the next morning, and you can't even start the diuretics till 7 o'clock that night because they have a history of VT and it took you all day to replete the K. that's where ultrafiltration will allow you to get that volume off without having to worry about potassium and magnesium.
I agree, and very great points, Dr. Haas. And I think the other thing, I alluded to this, but it wasn't in the list of publications you saw, but we published data a few years ago on HFpEF and ultrafiltration, and our outcomes were exactly the same as HFrEF.
We have something, one of our residents did the exact same thing and found the same.
Yeah, everyone's concerned about preload, which they should be, right, in the setting of diastolic dysfunction, and we're going to unload them too quickly and the cardiac output's going to decline, blah, blah, blah. Once again, if you're thoughtful with it, you can do it and it works. So just something to keep in mind for everyone out there. We'll go just sort of briefly through this pathway, and I think you've heard about this a little bit already. And my sort of assessment of this is that earlier is typically going to be better. And how could you identify patients that are diuretic resistant? I think a lot of people have been faced with someone who's been in the hospital for 10 days, 50 pounds overweight, who've been slammed with diuretics, the creatinine doubled, and now they're calling you for ultrafiltration. Well, that substrate's not as good as it could have been if they would have called you on the front end. So the identification of these patients early makes a huge amount of difference. And a lot of that really comes down to how can you identify someone who really is diuretic resistant? And you can assess this very quickly. You could do a furosemide challenge, as you appreciate in our pathway here, and really look and see what kind of a response do you see. And you can also look at spot urine sodiums, which are relatively easy to accomplish in an ER or in a clinic or anywhere else. You could do those sorts of things. And that's really going to give you an idea if you're really very much, on the fence, or even if you're really more of a diuretic kind of an approach, hospital or provider. I think that this flow diagram gives you some insights into what you might be able to anticipate. And this is really what we're trying to do at our institution. And the other thing that the team stressed that I would absolutely underscore with 3 big red marks is the right heart cath. Unequivocally an important thing to do. And I'll tell you, some patients who we thought were hugely volume overloaded, and maybe this was decompensated heart failure, really their filling pressures actually were normal. And so not only can you find good patients, but you might avoid an untoward outcome by doing the right heart catheterization. The other piece is this idea of a refill, and Dr. Watson alluded to this a little bit, but those extra vascular volume states, you are going to get refilling into the intravascular space, and maybe you just need to dial down your rate a little bit, allow that to reaccrue, and then you can take more fluid off, right? So all these things are important information. So I think this was a wonderful discussion, and I think everyone can see that obviously our goal is that idea of euvolemia, and can we really get there? And we can. And I think you can get there quicker and with less side effects, if you will, as you heard from Dr. Haas, by using ultrafiltration. Obviously, it's not for everyone, but there are a select group of patients. In our own experience, I had a patient who came in, we got off 55 pounds, and he said he hadn't felt that good in 30 years. So, this is just one example. So I understand sodiums and potassiums and weights and all that kind of stuff. Think about quality of life. It's a big component of this that we really see an improvement in. So with that, next, I think that might be the last slide. I think we'd love to hear from everyone. Any questions? I think everyone would be happy to entertain them.
Thank you so much, Dr. Jeffries and Maureen, Dr. Haas, Dr. Watson, and Patty. This was just very, very enlightening, informative, and very provocative, I think. Some questions from the audience, and these we've heard some from some of our the field is, since COVID, have you all seen in your practice an uptick in the number of heart failure patients? We hear a lot about COVID. We know patients came in with a lot of volume overload initially, and then we're hearing about that sequela of some myocarditis and other cardiovascular pathology. And so are we seeing patients now with heart failure related to being exposed to and having COVID-19?
I don't think we have. I would, in fact, if anything, during COVID, we saw less heart failure patients for sure. Part of that was related to people being afraid to come into the hospital. I don't think, there's a whole lot spoken about COVID myocarditis. To me, I don't think the data is at all clear whether or not COVID's unique in causing a viral myocarditis. Probably not. So sure, you can get a viral myocarditis with COVID, but I don't think there's a particular predilection for COVID-19 that I'm aware of in causing myocarditis more so than other viruses. So on a whole, but Patty, you know these numbers better than I do, but I don't think we've seen a particular uptick at all.
I don't think we've seen an uptick in heart failure, but I think that what we have seen, is patients who come in with more volume because they have avoided us for this period of time during COVID. So I think what we're seeing right now on our heart failure unit is patients who we may know from the past who are simply just more volume overloaded and would actually benefit from ultrafiltration and aquapheresis because they just delayed seeing anybody. So we're seeing them for the first time with lots and lots of volume.
Great, thank you for that. There was another question just talking, this is probably to Dr. Haas, but just you talked a lot about the right heart failure, the preload dependent person, and in terms of using this therapy in the context of caring for patients, maybe in the pre and post VAD setting, because we know those people are so fragile and just can get very volume overloaded initially, and then how do you tune them up so that you can safely implant them? And then oftentimes after we put the VAD in, the right ventricle is a little cranky until things can kind of get adjusted. So I'd be glad to hear your comments on that.
I mean, there's no reason not to use it. I don't think it's particularly indicated or contraindicated, but yes, to the point that these patients will often have significant RV failure, especially in the long haul, perioperatively. I first used that. I worked at Mount Sinai before, a couple of jobs ago, but and they used it in New York, and they used it a lot there in the perioperative, postoperative period in particular, for all cardiac surgeries. But certainly, you can use it postoperatively in VAD patients, and we've used it to tune them up. We've used it after the fact, and then especially, the DT population where folks have done pretty well, but 2, 3, 4 years out, develop RV failure as their predominant driver of their physiology. Yeah, it's especially helpful there. Again, I think you're going to follow as far as the preload. I kind of agree with Dr. Jeffries. I think probably too much is made of that. You just watch the urine output very carefully. I mean, we're always under the gun to not put in a Foley, but in this patient population, if you need a Foley, get a Foley. If they can't urinate in the urinal so you can track it accurately, get something that's going to accurately measure the urine output. To me, that's what I follow most, right? I think I don't see a whole lot of swings in blood pressure. I don't see people starting at 130 and dropping into the 80s. That doesn't happen. The concern is the blood pressure going in, right? But the urine output is particularly important. Creatinine too, and we check the metabolic panel every 12 hours, but I put a whole lot on that urine output. So that's how you're going to know how you're doing. And by the way, regardless of what you think, because they have to refill their intravascular space as you draw volume off. And so even if you think you've got adequate filling pressures in terms of their preload, you still have to be mindful of what their urine output is. So and if nursing or the powers that be are giving you pushback for putting a Foley in, again, the people that you're doing this on are incredibly sick. I think in cardiology, we often kind of get lulled by the fact that we deal with such sick people all of the time that it's the hernia patient that doesn't need a Foley. Okay. These people need a Foley. So do it because you need it.
Right. And I agree with that. The most sensitive parameter really in gauging whether your plasma refill rate is adequate is really the urine output. And, if your blood pressure is dropping precipitously, you really miss the boat. That's a late actor.
Yeah.
Great. So another question that comes in is, it looked like the way my understanding is your service works, the patients will come in and then you all are a consulting service. And in your study, it was almost a week. It was about 5.6, almost 6 days before they actually got onto ultrafiltration. And I guess one just has to think, because your results were certainly very stunning and very applicable to the real world and did reflect some other things that we had seen in the literature. But just this notion of early identification and using a protocol, how that would have changed the results and how things might have looked different, not only in terms of the patient outcomes, but also looking at how long they're staying in the hospital and maybe avoiding, Medicare's only paying for 3.4 days now. So anything longer than that. So from that economic standpoint, so if you could comment on that, please. Thank you.
I think it's changing, and Bob could speak to this also, but I mean, I got here, so ultrafiltration predated me. I got here in January of 2013. But we absolutely have patients now by the cardiologists, though. I don't know that it's coming so much through the hospitalists, but the cardiologists will do a right heart cath on their patient, see numbers, leave the ultrafiltration catheter in the right IJ, send them to the floor for ultrafiltration right from the get-go. So I bet if we redid this, in another 5 years or something, you would see that the date of initiation is becoming earlier than later. The duration of ultrafiltration, you can't control that. That's a function of how much volume they have, what rate you can run it at safely, et cetera. But certainly the lead time going into it is your opportunity to chop off days at the end for the total length of stay.
Yeah, and I would agree with that. Over these years, the cardiology groups have really gotten very astute. They're calling us from their office, with a patient, asking us to get involved as they send the patient over to the ER. But I think one of the big, elephants in the room is the fact that, notoriously, providers are not that great at identifying or judging volume overload, and therefore not that great at judging whether or not they've, developed euvolemia. I think it's more of, like Dr. Haas says to the residents all the time, just because you gave 80 of IV Lasix twice a day doesn't mean they're diuresing. But unfortunately, that's probably the mindset. And then the patient's here for 6 days and it's time to get them out. And, it's all water under the bridge at that point. But I think that's part of the problem too. It's not really clearly recognized that this patient is still very volume overloaded. Or the degree
I also think that's where the nursing part of this comes into. We have a heart failure unit, and our nurses get a lot of heart failure education from this team here, as well as just general nursing kinds of education. So they are often the ones that are recognizing and reaching out to primaries and cardiologists to say, what do you think? And sort of just bringing it up again, because it's not something that we're doing every day. So sometimes it's just, you have to think about it. So I think that's where they come in, not as far as monitoring the therapy, but also they're often the people who are bringing it up. Do you think this is a good patient for this?
Great. And then Dr. Jeffries, did you have any similar experience at your institution with protocols and identifying patients?
We have, and I think it's been an iterative process, as I think you're hearing, is that, you learn a little bit more. And it's not, if you think about it though, it's not so much always, the cardiology team. It really is going to be those hospitalists and the ER docs, right? Those are the folks you have to educate. And that's been our effort, is to try and make it simple and straightforward and have access to us to make sure that we can get this stood up relatively quickly. And I think maybe Patty said this, but in my role, we have a lot of fellows, obviously, that I have to sign off on every year when they graduate, and that we're not really teaching people how to assess volume status very well anymore, because we're such an imaging and serologic based subspecialty now that people have lost the ability to perform good clinical exams. And I think that those points are very well taken. And remember, okay, we're going to look at a BNP. Great. Well, what if most of the volume is extravascular? So a lot of these things have to be considered, right? And I think the other things that are important is that when you read literature, you think about this idea of worsening renal failure probably isn't the best phrasing for what we're talking about. Is that, remember, you're going to see fluctuations in creatinine, for example, But there are data out there to suggest that even if you induce AKI with either diuretics or UF, if you volume unload the patient, their outcomes are still better. So in measurements of AKI, for example, like discrete biomarkers of AKI, the people that did best, those numbers actually went up a little bit. So just keep in mind that you have to look at the whole patient. And it's not just about, well, the creatinine went up by 0.2, I've got to stop everything. No, as you heard from Dr. Haas, is the patient still overloaded? Then reassess what you're doing. So thank you very much. I thought this was a wonderful session. I really did. And I appreciate everyone's input. And Linda, we'll turn it back over to you.
Great. Thank you so much, Dr. Jeffries. There was one last question for the Abington team, just in terms of publication. And there was some interest in knowing more intimately, I think, the right heart cath numbers. So if there's any plans to share that information.
Yes, we're doing further analyses on our data, which will include much of that with plans to publish.
Great. Well, thank you all so much for taking time out of your day to share with us, and thank those of you who are on the Zoom call. As I said earlier, it'll be available on our social media channels within 24 hours. And please feel free to reach out to any of us here at CHF Solutions, and we'll be glad to put you in touch with the Abington team or Dr. Jeffries for further questions. So y'all have a nice day.